in this computer. Screen. Okay. I hope you can see my slides. Let me know if you can't. Well, as I say, good morning, good day, everyone, and welcome to Pediatric Teaching. We're going to talk about the management of common critical illnesses in children, and try to learn about how just basic history taking and clinical signs can give us a good understanding of the severity of illness of a child, and how we can monitor them properly, and differentiate the different types of critical illness a child has. I think we get used to, in a way, thinking of every child who has respiratory distress as having pneumonia, but in fact, there's lots of different things that lead to respiratory distress, and it's a good idea to be able to differentiate those from pneumonia, from bronchiolitis, from asthma, from upper airway obstruction, etc. So we'll talk about that today and a few other common conditions, and we'll see where we get to. So this is a child, I hope you can see the x-ray. This is a child who was 13 months of age, and he presented with 2 days of cough and fever and respiratory distress. And this was his x-ray. He had cough, fever and respiratory distress for 2 days. And when he presented, he had a respiratory rate of 70. He had severe chest indrawing. He had a heart rate of 170, so tachycardic, and he had a saturation that was 82%. So he was quite hypoxic. And he had, when you look at the way he's breathing, he's got a prolonged expiratory phase to his breathing. Now, I'm not sure whether you're used to looking at that, but when you look at a child who's got respiratory distress, it's a good idea to look to see whether the duration they breathe in and out is about the same, or whether it's more prolonged breathing in or more prolonged breathing out. And normally when we breathe, we have we take more time to breathe in because we have to use our respiratory muscles to breathe in, but then the breathing out is just a relaxation of those muscles, and it doesn't take as long. But if you've got a child who's got a very prolonged expiratory phase, that is, they take a long time to breathe out, so they're breathing like this. They're taking more time to breathe out than they took to breathe in, then that can tell you something about the underlying problem the child has. So from now on, when you're examining children, just have a look at that. And this child had a lot of wheeze on auscultation of his chest, and he had a lot of crackles. So what do you think's going on with him? He's got tachycardia, tachypnea, hypoxemia, a prolonged respiratory phase, lots of wheeze, and lots of crackles. And can anyone suggest what might be going on? Say that again.
Could be having an asthma attack.
Yes, that's right, Ernestine. He could be having an asthma attack, couldn't he? And now, of course, he could have pneumonia, and this could be a response to pneumonia. He could have bronchiolitis, but he could be having an asthma attack. And I suppose what I'm trying to convey today is sometimes we just get used to treating this type of clinical scenario with just antibiotics. We would normally give amoxicillin, or we'd give amoxicillin and gentamicin, or we'd give standard antibiotics for the severity, for severe pneumonia. But he could also, based on his clinical signs, that prolonged expiratory phase, remember he's breathing a bit like this. He's taking longer to breathe out than he does to breathe in, and he's got a lot of wheeze. You can hear the wheeze from the bedside, and if you listen with a stethoscope, and he's got lots of crackles, he could be having an asthma attack, and it might be that some other therapies would benefit this child. So what would you do if you saw a child breathing like this? He's got an oxygen saturation of 82. Looks like he's got severe pneumonia. He might be also having asthma. What things would you do? Well, I wanted to go back to the basics. We should always go back to the basics and think about what are the stages of management in any sick child. And this is from the Hospital Care for Children, the WHO book. And you know that the stages of management, first of all, is triage, which I've given you some information about this child's triage category, and then emergency treatment. Now, do you think this child needs any emergency treatment? He's got, what would you do, Ernestine?
Would give him oxygen because he's hypoxic.
Yes, that's right. Give him oxygen. And oxygen can fix a lot of problems. If you make him less hypoxic, his respiratory distress might get better. He might be less irritated and upset or distressed. You certainly give him oxygen. You take a history and do an examination. You do some laboratory investigations if needed, including a chest X-ray. Think about the main diagnoses and other diagnoses. Then give the appropriate standard treatment and then supportive care, and then monitoring and discharge planning and follow-up. And I wanted to just emphasize that every seriously ill child, we should go through those stages. But in the early stage, often it's just triage and emergency treatment and taking history and doing an examination. So with this child, when you do a triage, then you need to take a brief history of the presenting problem. The brief history was that this child had 2 days of cough, fever, and respiratory distress. That's really the briefest of history that one could take. Take a brief history, take the temperature and weigh the child. You weigh the child just so as you know what how to calculate drugs and to assess the child's nutritional state later on. You listen for stridor or obstructed breathing. This is for the airway. For breathing, you look for cyanosis and signs of respiratory distress like chest indrawing or tracheal tug, and you check the oxygen saturation. And for circulation, you feel the skin temperature of the hands and feet, all right? You need to get good at doing that, feeling the skin temperature of the hands and feet, feeling the radial pulse or the pulses in the feet, like the dorsalis pedis pulse or the posterior tibial pulse, and check the capillary refill time. Now, a child who's got shock will have cold hands and feet, they'll have weak pulses, and they'll have a very prolonged capillary refill time. And so if you feel their hands and feet and they're warm and their pulse volume feels okay, and their capillary refill time is 2 seconds or less, then you know that their circulation is probably okay. And then you assess the child for lethargy and the level of interaction. That's really all you need to do at triage. And then you need to think, does this child have any emergency signs? So what emergency signs did this child have?
Severe respiratory distress.
Yes, he had severe respiratory distress. He also was hypoxic, so he probably had central cyanosis, and he had some element of obstructed breathing, but certainly severe respiratory distress was the main one. So as you say, you would need to give oxygen. And what I wanted to do in terms of we would normally give oxygen and antibiotics, and we'd keep the child probably nil orally for the time being, and we might do a chest X-ray to have a look, and we'd see how the child went. I wanted to talk about, obviously this child would need oxygen and antibiotics, but what the place of using bronchodilator therapy in such children is. Now, if a child's under 6 months of age, they almost never respond to any bronchodilator therapy. But if they're about 9 months or 12 months of age and they've had wheezy illness before, and they've got a prolonged expiratory phase, or they've got wheeze on auscultation, then they may respond to salbutamol or other bronchodilators. And so I would, in this circumstance, give the child antibiotics to treat the bacterial infection, the pneumonia, if it's present, give oxygen, and then consider whether giving salbutamol would be of help. Now, there are many different causes of lung hyperinflation. Now, when I showed you the X-ray, I hope you were able to see that there doesn't look like there's much in the way of like consolidation. There's not much in the way of pneumonia in this X-ray, but what you can see is that the lungs are very well inflated. See how black they are. The lungs are inflated, and the diaphragms, this is the right hemidiaphragm, is quite flat, and the left hemidiaphragm is low, and that suggests that there's lung hyperinflation. And when you see a child who's got pneumonia, usually there's not lung hyperinflation. There's usually actually small lung volumes, not large lung volumes. And so there's a number of different causes of lung hyperinflation. And we've talked about a few of them. So asthma and bronchiolitis, they both cause the same type of lung hyperinflation. Remember, bronchiolitis occurs in children usually under 1 year of age, but certainly we see bronchiolitis up to 2 years of age. And beyond that, it's more likely that the lung hyperinflation and the wheeze is due to asthma. Sometimes it's much rarer, of course, but you need to sometimes think about a foreign body obstructing the airway, causing lung hyperinflation. Sometimes a foreign body will be half obstructing the airway, so the air can get in, but it can't get out. And that can lead to the same clinical signs of a child having difficulty exhaling. They can inhale okay, but they have difficulty exhaling, and their lungs become further and further hyperinflated. And then sometimes there's a congenital obstruction to the airway that lets the air in, but it means that there's trouble getting the air out, and that can be like bronchomalacia or something like that. The main thing is to try to identify children that have lung hyperinflation from those that have small lung volumes and consolidation. Small lung volumes and consolidation is more likely to be due to pneumonia or TB, those types of things, but large lung volumes with hyperinflation and wheeze are more likely to be due to asthma or bronchiolitis. Yeah. Now, sometimes there can be some bacterial pneumonia as well, but we need to identify these lung hyperinflation to think about other therapies that might be useful. For example, when you've got lung hyperinflation and bronchoconstriction, then using salbutamol or Ventolin can be useful, or aminophylline, sometimes theophylline. Using adrenaline sometimes can be useful, and prednisolone. And sometimes children, if they're not responding that sufficiently enough to oxygen, can settle down when you put them on CPAP. So using CPAP can be helpful. Sometimes using nebulized saline to help secretion clearance in babies with bronchiolitis that are producing a lot of secretions that block the airways that lead to that lung hyperinflation, that can be helpful. And sometimes using magnesium in children, certainly in children who've got asthma, can be very helpful. And these are mostly medications that are available. Even magnesium sulfate is available in PNG, and salbutamol is usually available, and theophylline is available. So it is possible, if you can identify these patients that have a component of lung hyperinflation and wheeze, airways disease, then you can treat them a little bit more than just giving oxygen and antibiotics. Now, most children don't need all of these things. They might need one or two of them, but whatever's available and tailored to the type of the age they are, whether they're more likely to have asthma, in which case salbutamol and Ventolin would be better, or whether they're more likely to have bronchiolitis, in which case hypertonic saline can help settle their secretions that they produce, etc. There's been lots of studies done about this thing called hypertonic saline, which is a very concentrated form of saline, and probably hypertonic saline is beneficial for babies with bronchiolitis. Now, the problem with it is that it's not readily available in PNG. 3% or 6% sodium chloride. We don't usually have that degree of concentrated sodium chloride. So Dr. Gordon Pukai, for his master's project, or his diploma, I should say, he did a study of just using normal saline, and he found that most of those children with bronchiolitis of moderate severity, who are less than 2 years of age, who, when they received nebulized normal saline, they had less respiratory distress after 4 hours, and they had an improved oxygen saturation, and they were more likely to be discharged. Now, of course, you still need to give these children with moderate pneumonia and bronchiolitis, you still need to give them antibiotics, and you need to follow them up carefully, but this can be a good adjunctive therapy for children who've got severe bronchiolitis. And they may or may not also respond to salbutamol, depending on their age and the likelihood that they have more likely to be asthma than bronchiolitis. Magnesium sulfate is very useful in the treatment of asthma in older children, and there's lots of reasons why magnesium can be beneficial. It can be a bronchodilator, and it has some anti-inflammatory properties, and it's mostly used in children over the age of 2 who've got asthma, it can be very helpful when you've got a child with severe asthma and you've given them salbutamol and you've given them steroids and maybe aminophylline as well, and they're still not improving or they're slow to improve. Magnesium is a very safe medication to give to children with bad asthma, and even it may work in some younger children with bronchiolitis. I wouldn't use it in children with mild or moderate bronchiolitis at all, but if they've got very severe bronchiolitis, I tend to give them some magnesium sulfate, and sometimes that can settle down there, especially if they're older children in the 9 to 12 months of age. So there are some, as well as oxygen and antibiotics, there are some additional things that you can give to children who you think have asthma with respiratory distress, or older infants with bronchiolitis, or infants in the second year of life with bronchiolitis. These are pictures, I did show one of these last week, but these are pictures of 2 children who had bronchiolitis, and you can see just again how black their lung fields are and how hyperinflated their chest is. And again, I want you to be able to distinguish between the child who most likely has pneumonia and the child who most likely has asthma or bronchiolitis, because there are some additional therapies that can be of benefit in those children. Right. Let's go to another case now. This is a 2-year-old girl who had 3 days of cough, fever, and respiratory distress. Now, she had, a bit of a similar story, cough, fever, and respiratory distress. On examination, she had lots of crackles and she had cyanosis, and again, a very prolonged respiratory phase. But when you ask the question about her, she had a history of stridor, noisy breathing on inspiration every time she ran around. She was 2.5 years old, and she could run around, but she would always get a stridor. And so this is a clue to it's not just acute. There's acute on chronic. There's something else going on, something underlying this, right? And so sometimes we need to think about what would cause acute respiratory distress, what that is presenting over just a few days, and what would cause a chronic respiratory disease. And I think a lot of the children we see have acute on chronic respiratory distress. Not all, but many of the children that keep coming back to our hospital and with recurrent pneumonia, what we say is recurrent pneumonia, often they have acute on chronic respiratory distress. And we need to make a distinction between the child who's previously perfectly well, no respiratory illness in the past, and then gets pneumonia, or then gets bronchiolitis, or develops asthma, to the child who has acute on chronic respiratory distress. And that just involves taking a really good history. So when we think about acute on chronic respiratory distress, this child had stridor whenever she would run around. And so you need to think about acute on chronic upper airway problem. Now, stridor being a noise on inspiration, that is, every time she breathed in, she had a raspy noise. You need to think about what might cause acute on chronic upper airway obstruction. Now, there are many things that could do that. For example, if a child has laryngomalacia, they're born with a floppy larynx, and that can cause acute on chronic respiratory distress from laryngomalacia. I'm sure some of you have seen that. Those babies are usually don't look very toxic. They don't look very unwell, but they've got stridor constantly. And if they get a cold or a respiratory tract infection, their stridor often gets much worse. The second thing is asthma, and that can be, again, because it's so common, we need to think about the child. If a child's got acute on chronic respiratory distress of any sort, then we need to think about, could it be asthma? Because asthma occurs in episodes, and sometimes the child's well in between, and sometimes they have some other symptoms that persist in between, like they might have a cough at night, or when they run around, they get breathless. That's often the case in children who've got like chronic persistent asthma. When they get a cold, they get a worsening of their a worsening episode of asthma, but in between, they might either be back to normal and have good exercise tolerance, or they might still have some respiratory problems. There are some children that have what we call recurrent croup. So you all know what croup is. It's due to a virus, and it causes just airway obstruction, upper airway obstruction. And for most children, they just get one episode of croup, and that's all. they get over their virus and they don't have a problem. But there are some children who have what we call recurrent croup. Their airway is anatomically normal. They don't have laryngomalacia, but frequently they might get a virus and they get recurrent croup. And it's a bit like asthma, that they get acute on chronic upper airway problem. All right. Thirdly, there are some children that have recurrent pneumonia, and that can lead to an acute on chronic respiratory problem. Or if a child's got an inhaled foreign body, that can, if that's, a child of 1 or 2 years of age who inhales a foreign body, often they get flare-ups of infection or mucus production, and they get acute on chronic respiratory disease. Right? And then there are some cardiac problems that can lead to acute on chronic respiratory problems. So the point is, if you see a child who you think might have acute on chronic respiratory disease, think, is it acute on chronic upper airway disease? Is it acute on chronic pneumonia? Or is it acute on chronic lower airways disease like asthma or recurrent bronchiolitis? Right? If it's acute on chronic pneumonia, perhaps they've got bronchiectasis, or perhaps they've got an inhaled foreign body. If it's acute on chronic airways disease, perhaps they've got asthma or they've got bronchiolitis. If it's acute on chronic upper airway obstruction, then maybe they've got laryngomalacia, or they've got recurrent croup, or they've got some other problem. Now, we sometimes monitor children with oximetry and sometimes their blood pressure, but I want you to look at the oximetry trace particularly. This is this same child that I was telling you about, and I want you to look at the oximetry trace, and you can see that the plethysmographic trace goes up and down. You see, just look at how it goes up and down. I bet you've seen children that are like this, where their oxygen saturation trace goes up and down like this. All right. Now, of course, there's up and down with every pulse beat, but what you can see is that the pulse wave goes up and down, but then it goes all the way down, and then it comes up again, and then it goes up and then goes down again. And it goes in this cycle. And I want you to look at that sort of trace, because even if you're using a desktop oximeter, or if you've got a bedside monitor, sometimes you can detect this change in the oximetry pattern. Instead of just going along flat, up and down along a flat line, it's going up and down. I hope you can see that, because what that reflects is obstruction. All right. And if you see that, then you've got to think, has the child got some degree of upper or lower airway obstruction? And if they've got that, if they've got this pattern that goes up and where the plethysmographic trace goes in a wave up and down, then it's very likely they've got quite severe airway obstruction, either upper or lower airway obstruction. And this is hard because if you look at the arterial trace, this is the arterial blood pressure, it also goes up and down in a wave. Now, normally we don't measure that, but I want you to be able to be alert to the oxygen saturation trace that goes up and down, because that indicates the child's got quite severe airway obstruction. It could be upper or it could be lower. If you look at what's happening, you can see, this is just showing you the monitor now, and see how it goes up and down like that. I'll just show you one more time, perhaps. Okay, and this child could have had any of those things that I mentioned, could have had recurrent croup, could have had laryngomalacia, but instead this child had a cardiac problem, a heart problem, and it's called, sometimes heart problems can lead to airway problems. This is quite unusual, but this child had what's called a pulmonary artery sling. And if you look at, this is a CT scan, and you can see the pulmonary artery, and it's wrapped around, the black is the trachea. It's wrapped around the trachea. So the point is, it's just a vessel wrapping around the trachea causing obstruction. But it could be anything causing that obstruction. It could be tracheomalacia. It could be a narrow trachea from any reason, or a tracheal foreign body. But the point is to recognize when a child has quite severe obstruction, and you can see that by the waveform on the arterial trace. Okay. All right. Now, the next case is a little different. All right. This is a 4-month-old boy who had failure to thrive and respiratory distress. And he was 4 months. He'd been, his growth had been poor. He had had chronic diarrhea, so episodic but persistent diarrhea. And he had respiratory distress that was moderate to severe, and fever and tachypnea. And his oxygen saturation when he came in was 65 to 70. So his temperature was 38.8. His respiratory rate was 70. His heart rate was 180. Now, if you saw him in triage, would you say he had emergency signs?
Sorry, Prof, could you repeat the question?
If you saw him in triage, would you say he had emergency signs?
Yes, because of the respiratory distress, the hypoxia.
That's correct. That's right. Respiratory distress and hypoxia, and maybe because the heart rate is 180, that might be, indicate a cardiovascular problem, but at least respiratory distress and hypoxia, a bit like the previous children, but the cause is different. Now, this child had in the emergency department, had a full blood count, and the hemoglobin was 11.8. That's okay. White cell count was 6.1. That's all right. Neutrophils of 5.8. That's okay. Lymphocytes were 0.3. That looks a bit low, doesn't it? That looks a bit low. And the platelets were 130. So that's a bit low too. This is the child's chest x-ray. Can anyone see anything abnormal on the chest x-ray? What strikes you as being abnormal? It's a little hard to see if you've never seen this sort of thing before, but this child's got a particular problem that I want you to identify, to be able to identify, because you will see it in other children. And I'll show you some other examples of it. I think you've seen this particular type of problem before. Can anyone suggest what's going on, what the problem is? So when we're looking at a chest x-ray, we need to look at the heart size and the heart shadow, and you can see the heart shadow reasonably clearly. You can see the left heart border reasonably clearly. You can see the right heart border reasonably clearly. You look for the left hemidiaphragm, and that looks reasonably clear. That's quite clear, isn't it? Doesn't look like there's any major consolidation up against the left hemidiaphragm, and the same with the right hemidiaphragm. There looks like there's some patchy sort of perihilar infiltrates, I think you'd suggest, and even behind the heart border, there's some infiltrates. The lung fields themselves look reasonably clear, don't they? There's a bit of infiltrate out from the perihilar region, but nothing too much. But there's something else that's really striking about the x-ray. It just looks strange because it looks like there's lots of, usually you see the mediastinum being opaque, don't you? If you look, I'll just go back to some previous x-rays and we'll just look at the mediastinum. That was a bit unusual, but let's see. Yeah, here you can see the mediastinum usually looks sort of white, doesn't it? Because it's opaque, because it's solid, isn't it? It's got solid structures in it. It's got the blood vessels, the trachea, of course, that's got air in it, and the esophagus. But it's reasonably opaque. I want you to look at this one too. The mediastinum is reasonably opaque. This has got a lot of patchy change, but just look at this mediastinum, and it doesn't look the same, does it? It doesn't look opaque. You can see perhaps the trachea there, but there looks like there's lots of other black lines here. What could they be? The black lines even look like they extend up into where the chin is, where the child's chin is, and outside even beyond the lungs, doesn't it? What could that be? And the black line extends all the way down here, near the left side of the heart, the left vertebral edge. Well, what could be going on here? Well, there's a number of different causes of this, but this is a pneumomediastinum, right? And so there's too much air in the soft tissues. You can see that air down there shouldn't be there. That air in the trachea should be there, but not the air adjacent to the trachea or air up here in the soft tissues. So there's air in the soft tissues. There's a pneumomediastinum. There might even be a pneumothorax because you can see it looks like some extra air around the heart. So this is this child has significant air leak of air outside the lungs. And sometimes people who have leak of air outside the lungs will get a pneumothorax, but sometimes they'll get a pneumomediastinum or subcutaneous emphysema. So when you feel that the skin around their neck and under their chin, it may be you may feel crepitus because they've got subcutaneous emphysema. So what you've heard the story of a 4-month-old boy who's got failure to thrive, chronic diarrhea, presents with hypoxemia, and he's got severe respiratory distress, and he looks like his lymphocyte count is low. What could be going on there? And he's got lots of air leak. What could be the illness he has? Okay. Well, you will see this clinical scenario on several occasions, I think. And the most common situation you'd see this in is if a child's got pneumocystis pneumonia, all right? And we get used to pneumocystis pneumonia often, of course, causing extensive patchy opacities symmetrically throughout both lung fields, but also pneumocystis can cause this air leak. And so this baby had an immunodeficiency with lymphopenia, like HIV, and he had severe respiratory distress with air leak. And that's very common in pneumocystis disease. So if you see a child, an infant who's got air leak like this and has got these other features of failure to thrive or chronic diarrhea or any other clinical features of HIV, then it's important to do a HIV test and check the full blood count to see if the child's got lymphopenia, or but particularly do a full blood count. The normal lymphocyte levels for age like 3,000 up to the age of 2 years or 3, and this was 0.3, so very, very low lymphocyte levels. So this type of air leak that I showed you on the X-ray, this type of air leak, pneumomediastinum or pneumothorax, can be caused by lots of different things. If you have a sudden increase in the airway pressure, like with asthma or a foreign body, and you have severe airflow obstruction, then you can burst a hole in the airway, but often from a heavy bout of coughing, like with pertussis, with whooping cough, or with pneumocystis, or with RSV bronchiolitis. But it's particularly seen with pneumocystis, especially. Sometimes you've got a child's got small cysts in the lung that burst when they have coughing, either because of tuberculosis or staphylococcal pneumonia, or with pneumocystis. And then occasionally we get air leak with a pneumomediastinum from like coughing or vomiting or some other thing leading to esophageal perforation, or sometimes children who've had a laryngeal trauma, like they've fallen over and hit their neck on a solid substance, or it's a relatively common rugby injury to have laryngeal trauma and have from a tackle and have a pneumomediastinum or subcutaneous emphysema. So you need to be able to identify. The main thing is today just to be able to identify air leak in the subcutaneous tissues or in the mediastinum that wasn't there, that shouldn't be there, air that shouldn't be there. Okay, here's another example of an air leak. So this is a child who's got bilateral pneumothoraces. All right, you can see this is the lung here, and you can see the air in the apices. All right, there's air in the pleura. And this was a child also who had pneumocystis, and you can see on the chest X-ray the lung fields themselves look a bit patchy and opaque. So this was a child who also had severe hypoxia, air leak, lymphopenia, and failure to thrive. That all adds up to pneumocystis pneumonia. And the reason to try to be able to diagnose that condition, of course, is that these children need standard antibiotic therapy, penicillin, whatever, but they also need cotrimoxazole to treat the pneumocystis. So that's important, and they need to have investigation for HIV and workup for that. This is a child who had air leak in asthma, and I hope you can see the extensive. This is not an artifact of the X-ray. This is real. You can see the air in the pleural cavity. You can see lots of air in the subcutaneous tissues. I mean, this child was very, very swollen because of air leaking out into the soft tissues around the chest and in the neck and in the head. You can see, and this is all air leaking out because of severe asthma. All right, and it's not common in asthma to have air leak, but when you do see it, it can be quite frightening for the child and for the doctors, nurses looking after the child, because it's hard to know what to do. But the main things are to try to reduce the amount of air that's leaking out by trying to calm the child, reduce the child's coughing, drain the pneumothorax if we can, but treat the coughing and the and treat the airflow obstruction so that there's less pressure causing air to leak out. This is also air leak in a child who had tetanus, and the child had again severe. This doesn't look that bad, but the child clinically was quite bad. You can see the air tracking up the neck here, and this occurred in tetanus after the child had a tracheostomy for tetanus, and because of the spasms, he was increasing the pressure inside his chest with every spasm. And so the treatment for this is to reduce the spasms and to reduce the pressure that's leading to the air leak. That's the main thing. All right. Well, we just got one case to go. I wanted to talk about one other case, which is not a respiratory case, but this was a 12-year-old boy who was previously well, perfectly well child, and he was playing soccer with some friends one day, and he had a sudden collapse. He wasn't struck, he wasn't knocked by anybody, but he just had a sudden collapse after kicking the ball. He was unconscious on the football field, and his father gave CPR. He gave cardiopulmonary resuscitation. Finally, an ambulance arrived, and they did a rhythm strip. They checked his rhythm, and they found this rhythm. What can you see? Can anyone see anything on the rhythm? Yes, can anyone, sorry, say that again? Yes, that's right. That's very good. It's a form of VT, yeah, a form of VT. And it's good to be able to recognize this form of VT. Now, I showed you a waveform before. You can see usually with VT, it doesn't go in this sort of waveform, but there is this is a type of VT. Does anyone know what this type of VT is called? Alani? VT is ventricular tachycardia, of course. Alani, were you going to say what the type of VT it is? It might be hard. I'm not sure whether might be that it's hard to say. But this is called torsade de poids. Torsade de poids. That's a French word, of course. And And all it means is sort of a waveform like this, all right? And VT is up and down. So this is torsade de poids, a type of ventricular tachycardia. That's right. And the ambulance officers, they had a defibrillator, and they defibrillated this child, and they got him back into a sinus rhythm. And so this is torsade de poids, and it's a form of ventricular tachycardia, or even worse, ventricular fibrillation. So he was able to be defibrillated back into a normal rhythm. And sometimes we can see this in previously well children. So he was a 12-year-old boy. He was normally active boy, but he had an underlying cardiac problem, not a structural problem, but just a small, very small problem that led to him having torsade de poids when he got very, I would just say, excited, or when he had a lot of adrenergic stimulation, like catecholamine stimulation. When you're exercising, or you're running around, or you've just kicked a goal, some sort of level of excitement leads to torsade de poids. In fact, there was a very famous soccer player who I think last year had a cardiac arrest. I think he was playing for an international team, had a cardiac arrest on the field from exactly the same problem, torsade de poids. And so this is the boy's ECG when he was defibrillated back into sinus rhythm. And you can see what the origin of his torsade de poids was, the reason why he had VF. And it's, can anyone see what this is? Maybe audio is not working, but can anyone see that abnormality? Very good, delta waves. Yeah, thanks, Ben. Delta waves. You can see the delta waves. And so, given that, what do you think this boy had as an underlying problem? That's right, Wolff-Parkinson-White syndrome, which is, you don't need to, I mean, for those who are sitting their masters too, it's good to know about this. For other people, you don't need to know too much about it, but this is Wolff-Parkinson-White syndrome. It's probably more common than we realize. It's it can be an inherited problem, and it can lead to a sudden cardiac arrest from torsade de poids. And what you should see is, this is the P wave, and you should see a PR interval, all right, the PR interval. But what you see there is a slurred upstroke on the R wave in just immediately after the P wave, all right? It shouldn't be like that. It shouldn't be that the R wave starts immediately after the P wave. But you can see this delta wave, which indicates that this boy had Wolff-Parkinson-White syndrome. And the important things about this is that it can lead to torsade de poids or sudden ventricular fibrillation when children or people of any age are subject to catecholamine stimulation when they're excited, or when they have any other reason for catecholamine stimulation. So after he arrived at hospital, his oxygen saturation was 50 to 60%. He'd had CPR on the soccer field, and he had this chest X-ray. What do you think could be going on? Can you suggest what's going on?
There's like heterogeneous opacity on the right side. It's only on the right, more on the right.
Yes.
And so he could have aspirated when he...
That's right. When he had a cardiac arrest and he was having CPR, he could have aspirated saliva or mucus from his mouth, or he could have vomited and aspirated during the episode. And he also sometimes after a cardiac arrest, when the heart has stopped but then starts beating again, there's a backflow of blood that leads to pulmonary congestion. So I think that combination of pulmonary congestion after a cardiac arrest, when the child's been successfully resuscitated, and having some aspiration led to his chest X-ray looking like this. By the time he got to hospital, his his ECG was good and his blood pressure was good. So you can hope that this boy is going to have a good outcome. He just needed some CPAP with 100% oxygen for a period of time. And he sometimes with torsade de pois, you can treat it with magnesium sulfate. If the magnesium level gets low, then you can give magnesium sulfate to elevate that, and that can stabilize the rhythm, make it less likely to go into the ventricular fibrillation. And then he needed antibiotics for aspiration, and he was fine after 24 hours of that treatment. So it's just I think this case tells you several things. One is that previously well children can have sudden cardiac arrest. It's not common, but they can have it. And usually it could be a cardiac rhythm problem. And the cardiac rhythm problem could have been there for all their life, but it's only manifest at one particular point in time. The second thing is that CPR, if done well, saves lives. And this child's life was saved by the father who gave CPR. And thirdly, after a cardiac arrest, sometimes you need to, even if it's been brief and the child's seemed to recover, sometimes they'll have some sequelae, like they have aspiration, or they'll have some what we call cardiogenic pulmonary edema, and it takes time for that to resolve, and some antibiotics, and you have to give some medicines to try to stabilize the heart. So with all of those things, within 24 hours, this boy was fine again. All right. So I've talked a bit about some critical illnesses in children, mostly severe respiratory distress and some cardiac illnesses. And I wanted to expand a bit on that triage, the way we assess children at triage, because there is a way of thinking about children who are have critical illness. And when I'm doing a ward round of children in the ICU or critically ill child, I always try to go through in my mind all of these things. And if you go through these things, it's good to have like an alphabetical list of things. So I always think to myself, is the child's airway okay? Or is the stridor or upper airway obstruction? What's the child's breathing like? What's the respiratory rate? What's the other signs of respiratory distress? What's the oxygen saturation? These are all for B. Sometimes we have a respiratory distress score that we monitor. What's the child's circulation like? I explained to you how to assess a child's circulation fairly quickly from feeling their hands and their feet. And then think about the child's D for disability. So it could be their neurological responses, their Glasgow Coma score, or their response to pain, right? D, I also review all drugs and check the drug doses and see what drugs are no longer needed, or which ones which ones are needed today. E is for like exposure or environment. So think about the child's temperature, think about their IV cannula or their nasogastric tube. Do they need these things today? All right. Think about their pressure areas as well. So under exposure, like expose the child, examine the child fully. E is also for electrolytes. So think about whether their kidney function is okay, or if you need to check their electrolytes, you may need to. With their F for fluids and feeding, think about are we nourishing the child well? Are we giving too much fluid? Are we giving too little fluid? Can we reduce the IV fluids and give more enteral feeding? Those sorts of things when you get up to F. G is for glucose. Is the blood glucose normal? Is the child on sufficient feeding or glucose? H is for hematology. So think about whether or not the child has anemia or some signs of infection on the full blood count. I is for clinical signs of infection, to make sure the child's not getting a nosocomial infection. So that's in a way, if you try to do this in a disciplined way when you're doing your ward round of children who have serious illness, then you won't miss anything. And you'll also teach other people how to be comprehensive in the way they assess a child. So when you're doing a ward round assessment of a critically ill child, then think in those terms. All right. Okay. Well, that's all I was going to say today, but I'm happy to answer any questions that you might have in the last few minutes. So thank you.